Okay, okay, guys, thank you for attending. I was tasked to talk about sudden cardiac arrest death in pediatrics. This is Mohammed Ibrahim. I'm associate professor at Department of Pediatrics, pediatric cardiologist, and electrophysiologist at Kuwait University. I do have a couple of platforms, so you can please check them out after the presentation. Today I would discuss how to approach sudden cardiac arrest through cases that I had encountered, but I will not discuss management because it's beyond the scope of this presentation, and I have no disclosures. Okay, so case one. This case started back in 2000. The index patient was 14 years of age at diagnosis or at presentation, sorry. He arrested while having an argument. And then he had a cardiac workup at the time, which was normal, and the diagnosis was unknown or idiopathic. He also had history of severe asthma, so no medications were given, especially like beta blockers. And the patient was like discharged without any therapy, which was strange, but this what happened. And then 2 years forward, he had repeated syncope, and then a transvenous ICD was implanted at the adult side. So the patient was, an adult at the time. And then going forward, he had multiple episodes of appropriate shocks, mainly when he is swimming. He was an active swimmer at the time, or has an emotional stress. So then, because of the multiple repeated appropriate shocks, he was advised to quit exercising. And then, indeed, after he quit, he stopped exercising, he had no further syncope or shocks. And then his family history is very impressive. He has multiple family members that died at a young age, especially while being active or with under emotional stress, as you can see here. And then he was a product of non-consanguineous parents. So before proceeding with the case, just really quick, sudden cardiac arrest death is a rare incident. It's very rare in children. It happens around 1 to 3 cases per 100,000 children. And then most cases do happen in apparently very well, like kids or children. And then obviously immediate CPR, AED administration can be very life-saving. And then details of the event is very critical in guiding further diagnostic testing. And then after the initial stabilization, further management is guided by neurological recovery and if there is any treatable cause. And then obviously there are many conditions that might present with sudden cardiac arrest. Each is rare, and then hence specialized teams need to be involved to figure out the diagnosis and treat accordingly. So despite extensive evaluation, often only less than 50% of individuals are diagnosed after a sudden cardiac event, and 50% will remain undiagnosed. And then the most common cause of sudden cardiac arrest or death in less than 35 years old individual are arrhythmia conditions. Okay. And then such conditions are largely heritable and include channelopathies or cardiac channel disease, or cardiomyopathies, which are cardiac muscle disease. So channelopathy is inherited arrhythmia disorders, again, like a cardiac channel disease, which is primary electrical disorder affecting ion channels, predisposing to sudden cardiac death. And like we said, they are largely genetic in etiology, and there's no cardiac muscle involvement often. And then, the most common channelopathy syndromes are long QT syndrome, of course. And then next would be catecholamine polymorphic ventricular tachycardia, Brugada syndrome, short QT syndrome, and early repolarization syndrome. But like we said, most common is long QT syndrome. And obviously, we need to perform multiple testing to figure out which channelopathy is the culprit for each individual. For cardiomyopathies, like we said, it's a cardiac muscle disease. So the anatomy is normal, but there is pathology within the cardiac muscles. Okay, muscle structure and function or function. And then such changes in the cardiac muscle would often result in infarctions, like microinfarcts, and with fibrosis, risking arrhythmia development. And then often it's again very often, like especially in the young individual family history, it's very often like it results from genetic or heritable disorders or genetic alterations or pathologies. And then specifically genetic mutations in proteins found in the sarcomere or desmosome, which is the proteins within cardiac muscles that that allow cardiac muscles to stick to each other, or the cytoskeleton network within the cardiac muscles. And then, unlike channelopathies, cardiomyopathies would have often abnormal imaging and cardiac workout. So cardiomyopathies are subdivided into multiple like channelopathies, most commonly hypertrophic cardiomyopathy, but also there is dilated cardiomyopathy, in which the muscles are weakened and thinned out. And there's arrhythmogenic cardiomyopathy in which there is predominant arrhythmia presentation, or more rarely left ventricular non-compaction or restrictive cardiomyopathies. Okay, and for cardiomyopathies, there are also non-genetic causes, but in our for the younger individuals is very often genetic in etiology. So there is increased LV trabeculations or arrhythmia burden or dilation or increased muscle mass or increased stiffness. Okay, so back to the case. So the patient, like we said, he had a cardiac arrest and then had multiple family members with cardiac arrests, okay, and death. So his ECG was largely normal, including like the resting ECG and ECG with leads placed at the upper chest to rule out Brugada phenotype. Okay. So why did I see the patient? He was an adult at the time, but the patient came to me because I needed to assess his kids because now he has two kids, and the adult EP wanted us to evaluate the kids and make sure they are not at risk of sudden cardiac arrest. Okay. They were referred to me for me to assess the kids, but I know the dad has a disease and the kids, I'm not so sure yet. So I carefully also examined dad, and I noticed that dad never had an exercise stress test. So, but like we said, had normal imaging and normal resting ECG. And so I did exercise stress test and I did, high chest lead positioning ECG. So when I did exercise stress test at peak exercise, there was, as you can see, multifocal PVCs, and then with bidirectional morphology. Okay, so there was multifocal PVCs at peak exercise, which is very pathognomonic for uh, CPVT. Okay, catecholamine polymorphic ventricular tachycardia. So in summary, the patient had obvious exertional or emotional arrhythmia, and then your main differential would be long QT syndrome because they might present with exercise or emotional distress or CPVT. Okay, but for our patient, the QT was normal even during exercise. So long QT was less less likely, and then CPVT was very likely given the exercise stress test findings. And with with long QT, we don't see ectopy during peak exercise. Okay, typically. So So the exit stress test was also very supportive of CPBT. Okay, so in other words, or just you please take note that whenever when you take history from a patient who had cardiac arrest, or in general, if you encounter history that suggests mid-exertional syncope, not after exertion, but during exertion, or with an absent prodrome like sudden and prolonged, and not while the patient is, not after prolonged standing, for example. These are very red flags for real pathology and life-threatening arrhythmia. Okay. Um, so even with video games, if the patient is very agitated during the video game, you might have ventricular tachycardia in CPVT patients, for example. Okay, so fast forward, I diagnosed dad with CPVT clinically, and then obviously genetic testing is the standard of care for all patients who present with sudden cardiac arrest that is unexplained, even explained, but with unexplained especially. And the uh, the the genetic testing came back positive for pathologic mutation in RYR2, ryanodine receptor, which is the specific channel that causes CPVT. Okay, so we have clinical diagnosis of CPVT and then gene genetic testing proving the diagnosis. Okay, so what happens in CPVT is that the sarcoplasmic reticulum is less able to contain calcium during diastole, and hence calcium is released during diastole, and that calcium is exchanged with sodium, and then there is, depolarization that is extra because of that exchange between calcium and sodium, as if you're having new or further depolarization, and hence cardiac ectopy or ventricular ectopy. Okay, so it's a very rare cause of sudden cardiac arrest or death in the young. Stress. This is why stress test is very important whenever you have a patient. As part of your workup, the patient should be evaluated with stress test. Okay, and there's also specific stress test protocols to further, um, you know, uh, enhance the phenotype of the CPVT. And then when you have multifocal PVC, especially bidirectional, this is a hallmark for CPVT diagnoses. Okay, so in order to diagnose CPVT, it's very simple. It is diagnosed when you have a normal heart with a normal ECG, but with exercise or emotion, you induce or you document bidirectional VT or polymorphic VT. Okay, or if the patient has a pathogenic mutation in RYR2 or calsequestrin gene. Okay, and then mind you, the VT should not be monomorphic. Okay, it's usually bidirectional or polymorphic. Okay, so obviously, after that ugly VT, the patient goes into VF and then cardiac arrest, of course. And then they of note, they also get atrial arrhythmias as well, not just ventricular arrhythmias, but obviously atrial arrhythmias are less life-threatening. Okay, so for take-home message here is that whenever you have a patient with a concerning family history, of course, you want to refer to cardiology, even if the ECG was normal at the time. And then CPVT, some diagnoses are often missed, for example, CPVT, because the ECG is very usually normal with normal imaging. Okay. And then, you have to refer to specialized centers because there's a specific EST or exercise stress test protocol that you should do. And such patients have a high penetrance, meaning they meaning they when they are not treated, they will get manifestation of the disease, which is usually highly malignant. So there's high chance of cardiac death or arrest in untreated individuals. Okay, so you have to screen at-risk family members because of that high penetrance, highly malignant phenotype. Okay, so if you want to know further about CPVT, there is and further about that clinical case, there's a separate presentation about that case in my YouTube channel. Okay, guys, so in summary, the patient had cardiac arrest, which was unexplained. There was positive family history in an autosomal dominant pattern. the ECG and imaging were normal except for exercise stress test. So with that in mind, channelopathy is very suspicious. And then with that specific history that we encountered, CPPT is very suspicious, especially that the ECG was normal in terms of long QT syndrome. So genetic testing should be done as a standard of care, and then it proved the diagnosis. Okay. Any questions, guys, about channelopathies in general?
لا تمام كده.
Okay.
تمام.
Please.
I can ask about syncope. What the red flags of syncope? If it's mid-exertional or exertional syncope,
Yeah,
this is a red flag.
yeah, mid-exertion, meaning يعني someone, let's say, plays soccer. He's playing soccer and then he gets tired, he rests, بعدين he faints. This is less concerning versus someone is playing soccer and then while he's running after the ball, he suddenly collapse. طبعا this يعني scenario 2 is much more malignant than scenario 1. Okay? Both might be concerning. You both need to be, like obtain good history and do, screening testing, of course. But scenario 2 is much more worsening, much more malignant, suggestive of malignant disease. Okay. So mid exertion is very, is a red flag. Okay. تمام.
تمام.
Or emotional, sometimes emotional, someone who is upset and then had a cardiac arrest. Okay, that might be a red flag. Of course, sometimes vasovagal might present with emotional upset as well. But طبعا with vasovagal usually there's no true cardiac arrest, مجرد fainting and hypotension. But in CPVT, for example, there's true cardiac arrest. Might be, these cardiac arrests might be prolonged and with seizure manifestations and so forth. Okay. Okay. So case 2, this is a family that is large, as you can see, with a complicated pedigree, but there is very high prevalence of dilated cardiomyopathy individuals and sudden cardiac death individuals. So hence there is muscle disease and there is also malignant arrhythmia manifestation in that family. Okay. So there is like roughly 13, 14 sudden cardiac death in this family. Okay. In young individuals. So just based on the pedigree, you definitely need to wonder about an arrhythmogenic cardiomyopathy in this family because there's like we said, 13 individuals roughly with apparently healthy suddenly dying at below 35 years of age. Okay, so that's very suggestive of a malignant arrhythmia in this family. Okay, and then because there is dilated cardiomyopathies as well, and cardiomyopathy, arrhythmogenic cardiomyopathy is a suspect just based on the history for this patient, for this family. Okay. So indeed, after gene testing, a couple of family members, there was a mutation in DES gene, which encodes desmin. And then desmin is part of the cytoskeleton network that provides strength and integrity to cardiac myocytes. Okay. And then when you have when that cytoskeleton is affected, there is obviously cell death and scar formation. Okay, and the desmin is expressed in cardiac cells plus the conduction tissue of the cardiac muscles. So hence the manifestation of desminopathies are often, could be cardiac muscle disease or could be arrhythmogenic in nature because of the, ventricular scarring and conduction disease affection. Okay, it's a rare cause of cardiomyopathies in general, and and other types of muscles might be affected, but less commonly. Okay, so in this family, there is multiple family members with cardiac arrest and cardiac muscle disease, or DCM, dilated cardiomyopathy. There is positive family history, so autosomal dominant inheritance is suspected. But in this case, so like we said, there is imaging pathology, so there is dilated cardiomyopathy, there's ECG changes. So we know it's not just channelopathy, there's also muscle disease involved. So cardiomyopathy is highly suspicious, and hence gene testing should be done. And in this case, Desmin was the culprit for this family disease. Okay, and Desmin is a very malignant type of cardiomyopathy, and when you have desminopathies, very often you have multiple family members that are affected like badly. Okay, so when to summarize, when someone arrests in the field, obviously for him to survive, often you need first responders to be at the site rapidly to perform resuscitation, and then hopefully the patient gets stabilized and then transferred to a specialized cardiac center in which investigation is performed, and hopefully diagnosis is found. And that you often involve multidisciplinary team. You want cardiologists, like cardiac imaging, you want cardiac electrophysiologists, you want cardiac geneticists, and obviously psychologists and so forth to support the family members. Okay, so it's a team effort. And then when someone arrests in the field, in general, like we said, cardiac arrhythmia is the commonest cause. So as a cardiologist, you want to always, just rule out initially myocarditis. Is there intoxication, electrolyte disturbances, or commotion cordis, which is like chest trauma? But if there's family history of sudden cardiac death in multiple family members, it's usually genetic. And when it's genetic, there are genetic diseases that cause cardiac conduction disorders, like sinus node disease or AV node disease, or cardiac muscle disease or cardiac channel disease. The cardiac muscle disease and cardiac channel disease, those are the ones that we discussed today. And then you want to, of course, make sure there's no severe valve disease that might explain the cardiac death, or if there's any coronary artery anomaly that might result in, infarction and sudden cardiac death. Okay, and then rarely WW might present with sudden cardiac arrest or death, and if there is rupture of a major artery, of course, or if there is significant dyslipidemia resulting in premature ischemic heart disease, and then lastly, if you cannot identify a diagnosis, but it's cardiac, it's idiopathic VTVF. Okay, but there are non-cardiac causes that exist that I will not discuss, of course, in this lecture. So in summary, cardiomyopathies are cardiac muscle disease or abnormalities in the cardiac muscle function, and channelopathies are cardiac channel disorders that result in cardiac electrical system disturbances and arrhythmias. Okay, obviously you want to refer to pediatric electrophysiology service when you encounter such pathologies, and then because both may lead to sudden cardiac death, and hopefully we will try to treat the condition so that we avoid sudden cardiac arrest or death. Okay. Okay. Let me just stop sharing. Any questions, guys, regarding the second case?
لا تمام دكتور محمد.